Every 40 seconds, somewhere in the United States, a person has a stroke. Every 3.5 minutes, someone dies from one. But here's what those numbers do not tell you. In many of those cases, not the exception, not the edge case, the person experienced warning signs hours or even days before, signs they dismissed as something else, signs that passed and were forgotten, signs that, had someone recognized them and acted, could have changed everything that followed. Stroke is the fifth leading cause of death in America. It is the single leading cause of long-term disability, and after the age of 60, risk does not inch upward slowly. According to the American Heart Association, stroke risk roughly doubles with every decade past 55. The warning signs are real. They are often brief. They do not always look the way you picture when someone says the word stroke. And after 60, they are the most important signals your body will ever send you. Today, we are going through 7 of them, specifically the signs most often dismissed, overlooked, or waited out until it was too late. Stay all the way to number 1, because there is one particular warning that neuroscience now identifies as the most urgent of all, and it is the one most commonly brushed off as nothing. Welcome. This channel exists to give you the medical context that almost never fits inside a short appointment, the science behind what your body may be telling you and why it matters. A quick note before we go any further, and I want to be clear about this. This channel provides general health education, not medical advice. I am not your doctor. Nothing here is a diagnosis. If you or someone with you is experiencing any signs of stroke right now, facial drooping, sudden weakness, sudden trouble speaking, stop this video and call 911 immediately. Those symptoms are a medical emergency. For everyone watching to learn, by the end of this video, you will know the 7 warning signs that stroke specialists most want people over 60 to recognize, including several that almost never appear on the simple awareness posters. And you will know exactly what to do the moment any of them appear. Because in stroke, the difference between knowing and not knowing is often the difference between a full recovery and permanent disability. Stay with me through all 7, especially to number 1. Sign number 1 is the most counterintuitive warning on this entire list. It is the moment when every symptom appears and then disappears completely. The person feels fine, relieved, and then within hours or days, a major disabling stroke follows. Neurologists have a specific name for what just happened, and the research on what occurs in the 48 to 72 hours after that moment and why acting immediately is so critical is something every person over 60 should hear once and never forget. That is sign number 1. Let's get there together. Before we go into the signs, tell me in the comments, how old are you and where in the country are you watching from? And if you have ever experienced a symptom on this list and dismissed it at the time, I especially want to hear from you. Those comments help other people reading them recognize what they may have experienced, and they help me decide what to go deeper on next. Now, let me give you the foundation that makes all 7 signs make complete sense. Here is the biology almost no one explains. The brain is the most metabolically hungry organ in the human body. It makes up roughly 2% of your body weight. It consumes 20% of your oxygen and 20% of your circulating blood sugar constantly, without interruption, every moment you are alive. Because of that dependency, the brain has almost zero tolerance for disruption in blood flow. When an artery supplying part of the brain becomes blocked by a clot that forms locally or by a clot that breaks off from somewhere else and travels upward, that region loses oxygen. The neurons in that region begin to die, not over hours, over minutes. A 2006 study in the journal Stroke, led by neurologist Dr. Jeffrey Saver at UCLA, calculated the rate precisely. During an active stroke, approximately 1.9 million neurons are lost every single minute. The phrase neurologists use, and it is exactly the right phrase, is time is brain. The symptoms of stroke are the outward signal of that internal loss. Which part of the brain is affected determines what the person experiences. a specific change in vision, a specific type of speech problem, a specific kind of weakness. The symptom is the geography of the damage. Here is why age 60 changes the equation. Two things happen to the vascular system after 60 that compound the risk significantly. First, the arteries stiffen and narrow over time, a process called arteriosclerosis, which reduces the buffer of the brain, has when flow is disrupted. Second, the tendency toward blood clot formation can increase with age-related conditions. Atrial fibrillation, an irregular heart rhythm that dramatically increases clot risk, affects roughly 1 in 10 Americans over 65, and many of them do not know they have it. The 7 warning signs we are about to go through are not vague. They are the specific documented signals the brain sends when blood supply is being threatened. Each one maps to a region of the brain and a function being put at risk. The moment any of them appear, the clock is running. Here are the 7 signs. Starting at number 7, building toward the one I most need you to remember. The warning your eyes are sending that almost no one connects to the brain. Sign number 7 is a sudden change in vision, blurred vision, double vision, or a sudden darkness or loss of sight in one eye. Pay close attention here. Because vision problems are among the most consistently under-recognized stroke warnings, most people who experience them immediately think, my glasses need updating. I need more light. I am tired. The connection to the brain and to stroke almost never comes to mind, and that delay costs time that the brain cannot afford. Roughly 30% of the cerebral cortex is dedicated to processing visual information. The visual cortex sits at the back of the brain in the occipital lobe and receives its blood supply from the posterior circulation, the vertebral and basilar arteries that run up through the neck. When blood flow to these areas is compromised, vision is often the first function affected. There is also a specific and well-documented scenario involving the carotid artery in the neck when a tiny clot or a fragment of arterial plaque breaks free and travels into the small artery supplying the retina of one eye. The result is a sudden, temporary loss of vision in that eye, not both, just one. Neurologists call this condition amaurosis, fugax. It typically lasts seconds to minutes and then clears entirely, leaving the person feeling normal and wondering if anything actually happened. Because it clears, people wait it out. Because it involves one eye, they do not think of the brain. But this event is one of the most direct early warnings of carotid artery disease and impending stroke that exists in clinical medicine. The retinal artery is a small branch fed by the main carotid trunk. A clot traveling down that branch is a message from the larger artery. There is debris moving through this system. Dismissing the branch signal because it cleared is like ignoring a small fire in a side room because it went out on its own, while the source of the fire is still burning in the wall. Research published in Lancet Neurology has established that amaurosis fugax, transient visual loss in one eye, carries a risk of subsequent stroke comparable to any other transient ischemic attack presentation. It is classified as a TI of the eye, and the risk of a full stroke in the days following any TIA, including a retinal TIA, is highest in the first 48 to 72 hours after the event. If you experience sudden blurring, sudden double vision, or especially a sudden curtain of darkness over one eye, even if it resolves in under a minute, call 911 or get to an emergency room immediately. Do not drive yourself. Do not wait to see if it happens again. Clot dissolving treatment for ischemic stroke is most effective within 4.5 hours of symptom onset, and time spent waiting is time lost. Vision changes are often the brain's earliest alarm and one of the most ignored. Sign number 6 involves a sensation most people attribute to something else entirely, and almost always without seeking help. The headache, that means something completely different. After 60, sign number 6 is a sudden, severe headache, but not just any headache. The specific headache that stroke specialists warn about has a character that separates it from a migraine, a tension headache, or a sinus headache. The description neurologists use is precise: the worst headache of your life, reaching its maximum intensity within seconds to 1 minute of onset. Some patients describe it as a crack, a pop, or an explosion at the back of the head, it is called a thunderclap headache. And if you've ever had one even once, even if it faded, it belongs on a list of things discussed urgently with your doctor. There are two major types of stroke: ischemic, where a vessel is blocked, and hemorrhagic, where a vessel ruptures and blood escapes into or around the brain. The thunderclap headache is the hallmark warning sign of subarachnoid hemorrhage, bleeding into the space between the brain and its surrounding membrane. When a blood vessel, often a weakened, balloon-like bulge in an artery wall called an aneurysm, ruptures, blood floods into that space almost instantaneously. The brain is enclosed inside a rigid skull with no room to accommodate. The sudden pressure, that explosive increase in pressure, is what produces the immediate maximal pain. Hemorrhagic stroke of this type carries a mortality rate of up to 30 to 40%. And research consistently shows that many patients reported a severe sentinel headache, a warning bleed, in the days or weeks before the rupture. Many dismissed it. Most did not seek care. A cerebral aneurysm is like a worn, thin patch on a high-pressure water line. Pressure builds against that patch over months or years. A sentinel headache is the patch beginning to bulge and weep before it gives way entirely. That warning is a window, and acting on it is exactly what changes the outcome. A systematic review in the BMJ found that in patients ultimately diagnosed with subarachnoid hemorrhage, approximately 20 to 40% had experienced a sudden, severe headache in the days prior and had not acted on it. Among those who did present immediately after a first sudden severe headache and were found to have a warning bleed, early intervention significantly reduced the risk of the catastrophic rupture that typically follows within 2 weeks. A sudden, severe headache that reaches full intensity in under a minute, unlike any headache you've experienced before, is a 911 call, not a lie-down situation, not a wait-and-see. Emergency services immediately, especially if the headache is accompanied by neck stiffness, sensitivity to light, nausea, or a brief loss of consciousness. Emergency imaging and evaluation can confirm or rule out a bleed within hours, and early detection dramatically changes what treatment can accomplish. The thunderclap headache is the most dramatic warning sign on this list. Sign number 5 is perhaps the most hidden, because the person experiencing it often cannot see it in themselves. Sign number 5 is sudden confusion or sudden difficulty understanding what other people are saying. It earns its place at number 5 specifically because it is the hardest warning sign for the person experiencing it to self-report. The individual going through it often cannot recognize that they are the one with the problem, and that makes it uniquely dependent on the people around them to act. In the vast majority of right-handed people, the left hemisphere of the brain contains both major language centers. The front portion, Broca's area, governs the ability to produce speech. The back portion, Wernicke's area, governs the ability to understand language that is heard. When blood flow to Wernicke's area is suddenly disrupted, the person hears words but cannot decode their meaning. They may respond, but the response is disconnected from what was said. They may feel genuinely confused about why no one seems to be making sense. They may appear to interact somewhat normally for short periods, but they are not processing the content of language. This is called receptive aphasia. Its defining and dangerous feature is that the person experiencing it may not know that anything is wrong with them. They believe the confusion is coming from outside, which is why family members, spouses, and people nearby are often the ones who notice first, and why recognizing it in a loved one is as important as recognizing it in yourself. Wernicke's aphasia is like the brain's language translation engine crashing mid-operation. The sounds of speech arrive normally at the ear. The decoding software is offline. The person is hearing what sounds like a foreign language where there used to be meaning, but they often do not know the engine has failed. They only know that nothing is making sense. A review in neuropsychological rehabilitation found that aphasia, including receptive forms, is present in approximately 30% of acute stroke presentations, making it one of the most common individual stroke symptoms. And yet it is consistently misidentified in community settings. attributed to confusion from low blood sugar, dementia, medication side effects, or distress, which delays the 911 call that starts the treatment clock. A simple bedside test for this sign. Ask the person to follow a two-step instruction. Pick up that cup and set it on the table. If they cannot follow it, give a response unrelated to what was asked. Or seem genuinely puzzled by a normal request. Treat it as a stroke warning and call 911. Do not try to re-explain. Do not assume they are confused for another reason until a stroke has been ruled out by emergency. Evaluation. Receptive aphasia hides in plain sight because the person looks like they are present and functioning. Sign number 4 is the sign most people know, but the nuance around it is what most people miss. Sign number 4 is sudden numbness, tingling, or weakness in the face, the arm, or the leg. This one appears on most stroke awareness materials, but what those materials often do not emphasize clearly enough is the detail that separates a stroke warning from a benign sensation. It is one-sided. This single characteristic is one of the most reliable features distinguishing stroke from other causes of sudden weakness. The motor and sensory cortex runs in a band across the top of each hemisphere. The left hemisphere controls the right side of the body. The right hemisphere controls the left. When a stroke affects one hemisphere, the motor and sensory signals to the opposite side of the body are interrupted, producing sudden weakness, sudden numbness, or a sudden dead weight feeling in that arm or leg. The face is mapped in the same cortical strip, one-sided facial drooping, one corner of the mouth falling, one eyelid unable to close fully, is the face's expression of that same interruption. In seniors over 60, mild one-sided weakness is sometimes dismissed as an arm that fell asleep, fatigue, or the effect of a long night's sleep. The key questions are 3. Did it come on suddenly? Is it one side only? Does it involve more than one area, the arm and the face together, or the arm and the leg on the same side? Those 3 features together are almost never benign. The brain is like a telephone exchange where one side of the building routes all the calls for the opposite side of the city. When one side of the exchange goes dark suddenly, only calls to that city half drop. If both halves of the city lose connection at once, that is usually a different kind of problem entirely. One-sided is the brain's signature for stroke. According to the American Heart Association's stroke statistics, sudden unilateral weakness or numbness is present in approximately 55 to 65% of acute ischemic stroke presentations, making it the most common individual symptom in the acute phase. Yet research published in the journal Stroke shows that when symptoms are mild or transient, recognition and the decision to call 911 are significantly delayed, even when symptoms are clearly one-sided. Mildness does not mean safety. Mildness in a stroke warning means the damage is not yet complete. The arm drift test. Ask the person to close their eyes, extend both arms straight in front of them, and hold the position for 10 seconds. If one arm drifts downward without the person's conscious control, that is a positive result. Combine that with fast balance, eyes, face, arms, speech time, and call 911. The moment you see it, do not wait for the weakness to worsen. Do not decide to monitor it for an hour. One-sided weakness is one of the clearest stroke signals the body sends. Sign number 3 is one that sends many seniors to the wrong evaluation because it looks and feels like something far less urgent. Sign number 3 is sudden loss of balance, sudden dizziness, or sudden inability to walk steadily, arriving with no clear trigger, no prior movement that explains it, and alongside at least one other new symptom. This one deserves special attention for people over 60 because it is the most likely warning on this list to be attributed to something else entirely. Inner ear trouble, a blood pressure drop on standing, or simply a misstep. But when it comes on suddenly and without explanation, it may be signaling a stroke in a part of the brain that most awareness campaigns leave out. Most stroke awareness focuses on the cortex, the outer layer of the brain responsible for movement and language, but approximately 20 to 25% of strokes affect the posterior circulation. the vertebral and basilar arteries that supply the brainstem and the cerebellum. The cerebellum is the brain's coordination center, the structure that synchronizes movement, balance, and fine motor control. The brainstem controls fundamental functions: balance, reflexes, eye movement, swallowing, consciousness. A stroke in the posterior circulation does not produce the classic one-sided face-arm speech presentation. It produces sudden loss of coordination, sudden severe dizziness, sudden double vision, difficulty swallowing, or a combination of these. It looks like a fall or a vertigo episode. It does not look like what people picture when they think of stroke. The B at the beginning of the BE-FAST acronym, balance, was added specifically to the original FAST framework because posterior circulation strokes were being systematically missed in both community and clinical settings. The cerebellum is the brain's gyroscope, constantly comparing what your muscles are doing to what your eyes and inner ear are reporting, and making thousands of micro corrections per second to keep you upright and moving smoothly. When blood flow to the cerebellum is cut suddenly, the gyroscope fails, not gradually, all at once, and the result presents as a problem with the feet and the legs, when the actual problem is inside the skull. A 2014 study published in the journal Stroke found that patients with posterior circulation strokes had significantly longer delays from symptom onset to hospital arrival compared to patients with anterior cortical strokes, largely because symptoms were not recognized as stroke by either patients or, in some cases, emergency responders. That delay directly reduced eligibility for time-sensitive treatment. For seniors in particular, sudden dizziness and loss of balance are among the most consistently delayed evaluation stroke presentations. Sudden loss of balance or sudden inability to walk steadily, especially when combined with dizziness, double vision, or any other symptom from this list, is a 911 call. The combination is what matters. Sudden onset, no clear trigger, and at least one other concurrent new symptom. Do not assume it is an inner ear problem without a stroke evaluation. Emergency imaging can differentiate a cerebellar stroke from other causes within minutes of arrival. Posterior stroke hides in the gap between what stroke looks like on a poster and what it looks like in someone's living room. Sign number 2 is the most widely recognized warning, but the context around it matters more than most people realize. Sign number 2 is sudden trouble speaking, words that come out slurred, garbled, fragmented, or not at all. The S in the BE-FAST acronym. This is the most publicized stroke warning sign that exists, and it still delays treatment, partly because mild speech change in a tired, older person is dismissed as fatigue, partly because it passes quickly, and partly because the person experiencing it sometimes does not notice anything is wrong. Speech production is governed primarily by Broca's area in the left frontal lobe, the region that constructs, sequences, and initiates speech before it is spoken. When blood flow to this area is cut, the person may know exactly what they want to say, but be completely unable to produce the words. They may speak in fragments, water, I, need, the, or produce words that are close but wrong, or they may be entirely speechless while fully conscious. This is expressive aphasia. It is distinct from dysarthria, where the language centers are intact, but the physical mechanics of speech are impaired, producing slurring or slowed articulation, which typically reflects brainstem or cerebellar involvement. In practice, both present as sudden speech change, both are stroke emergencies. For seniors over 60, mild speech changes are sometimes attributed to tiredness, medication effects, or just having an off moment. The critical question is whether the change was sudden and represents a clear departure from that person's normal speech. Broca's area is the brain's word assembly line. It takes a concept, I need water, and builds the sentence, sequences the syllables, and sends the output to the mouth. When the assembly line stops suddenly, the concept is still fully intact. The person knows exactly what they want to say. They simply cannot produce it. The experience of knowing but being unable to speak is one of the things stroke survivors describe most consistently and most devastatingly. Research published in JAMA Neurology found that patients who arrived at stroke centers via 911 Rather than being driven by a family member or arriving by private vehicle, received brain imaging faster, received clot dissolving treatment within the critical window more often, and had better outcomes. Paramedics can begin the assessment in transit and pre notify the hospital, which starts the treatment team before the patient arrives. Calling 911 is not just about getting there, it is about the treatment clock starting earlier. The speech test. Ask the person to repeat a simple sentence. The sky is blue in Cincinnati is the standard clinical example. Slurring, wrong words, inability to complete it, or significant visible struggle are all reasons to call 911. Do not offer food or water. Do not help them. Find the words, note the exact time symptoms started. Emergency physicians will need that information because the entire treatment timeline is measured from that moment. Sudden trouble speaking is the most recognized warning on this list. Sign number 1 is the least recognized and the most urgent, precisely because it is the moment when everything appears to have returned to normal. Sign number 1 is the presence of any symptom on this list: the vision change, the sudden headache, the confusion, the weakness, the balance loss, the speech problem. That appeared, lasted minutes, and then went completely away. The person feels fine, normal, perhaps slightly unsettled, but relieved that it passed. And so they wait, they go to sleep, they plan to mention it at the next appointment, or they decide it was probably nothing. This is the most dangerous decision a person over 60 can make after a neurological event. And neurologists identify this moment, the moment symptoms resolve, as the most urgent window in stroke prevention that exists. What the person just experienced is a transient ischemic attack, a TIA, commonly called a mini stroke. In a TIA, blood flow to a region of the brain is temporarily blocked by a small clot, a fragment of arterial plaque, or a brief flow interruption, and then restored before permanent cell death occurs. Symptoms appear, and because the blood flow returns, the symptoms resolve. No permanent damage, full recovery within minutes to hours. Here is what makes a TIA the most dangerous event on this list. The clot did not disappear. The arterial plaque is still there. The atrial fibrillation is still generating clot risk. And the condition that caused the temporary blockage has not been treated because the person never went to the hospital. And the brain that was just threatened is now in a period of heightened vulnerability. Research consistently shows that in the 48 to 72 hours after a TIA, the risk of a full, disabling, potentially fatal stroke is at its absolute peak. A study published in the New England Journal of Medicine and since replicated in multiple cohorts found that the 90-day stroke risk after a TIA is approximately 10 to 15%, and that risk is not evenly distributed across 90 days. The majority of subsequent strokes occur in the first 2 to 7 days after the TIA. Many occur within 24 hours. The reason so many people with TIA do not seek immediate care is the same reason it is so dangerous. They feel better, completely better, and the human mind, in the absence of ongoing symptoms, concludes that nothing needs to be done. A TA is the brain's equivalent of a fire alarm that trips, rings for 2 minutes, and then goes silent. Not because the fire is out, but because the smoke briefly cleared from the detector. The fire is still there. The source of the ignition has not been addressed. The window to prevent the building from burning is right now, not tomorrow morning when everything seems fine. A landmark study published in Lancet Neurology examined what happens when TIA is treated immediately, within 24 hours of symptom onset, versus treated with standard follow-up timing. Urgent evaluation and treatment, including antiplatelet therapy, blood pressure management, and imaging to identify the underlying cause, reduced 90-day stroke risk by approximately 80% compared to delayed management. 80%. That is the scale of difference that a single 911 call made while the symptoms were still present or immediately after they resolved can make. If you or anyone you are with experiences any symptom on this list and it goes away, call 911 anyway, right? Then tell the dispatcher exactly this: I think I may have had a mini stroke. The symptoms have resolved, but I need evaluation now. Emergency physicians will not send you away because you feel better. They will run imaging. They will look for the underlying cause. And the treatment they can initiate in that window within hours of a TIA is precisely what converts a warning event into a prevention opportunity rather than a precursor to catastrophe. This is not over caution. The American Stroke Association explicitly recommends treating resolved high I symptoms with the same urgency as active stroke symptoms. The evidence for why is unmistakable. Do not wait until morning. Do not decide it was probably nothing. Call 911. Every sign on this list matters. This one is first because feeling better is a signal most likely to prevent someone from receiving the care that could save their life. Consider a man in his early 70s. Call him Gerald, the kind of composite patient this pattern shows up in again and again in emergency neurology literature. Gerald is reasonably healthy for his age. He walks daily, manages mild blood pressure with medication, and has no history of stroke or neurological events. One Tuesday afternoon, sitting in his chair watching television, he notices something strange. For about 3 minutes, his right hand feels weak and tingly, not quite cooperating. He shakes it out, flexes his fingers, and it passes. He decides it was probably the way he was sitting. Thursday morning, he wakes up, and for perhaps 90 seconds, the left side of his face feels oddly numb. When he tries to say his wife's name, the word comes out garbled. It frightens him. Then it resolves completely. He feels entirely normal. He does not tell his wife. He decides not to worry her. Friday afternoon, Gerald has a major ischemic stroke, left-sided weakness, expressive aphasia that does not resolve over days, weeks of hospitalization, months of rehabilitation, and a permanent change in his ability to live independently. The Tuesday hand weakness was a TIA. The Thursday facial numbness and speech disturbance was almost certainly a second TIA. The Friday stroke was predictable in the most specific sense. The risk at that point was measurable, urgent, and known to be highest in exactly that window. Gerald had two separate opportunities in which emergency evaluation could have identified the carotid artery plaque driving these events and begun the treatment that the evidence shows reduces subsequent stroke risk by up to 80%. The composite case is not unusual. It is, in fact, the pattern. Gerald did not have the information. He did not know that resolving symptoms were not the all clear. He did not know that feeling better was the moment to call, not the moment to relax. Now you do. Let me bring this together with what I want you to actually carry out of this video. 7 warning signs, 7 moments the brain may be sounding an alarm. 7. Sudden vision change, blurred, double, or darkness in one eye. 6. A thunderclap headache, the worst of your life, reaching full intensity in under a minute. 5. Sudden confusion or inability to understand what others are saying. 4. Sudden numbness or weakness on one side, face, arm, or leg. 3. Sudden loss of balance, coordination, or unexplained falling alongside other symptoms. 2. Sudden trouble speaking, slurred, garbled, or words not coming out. 1. Any of the above. Even if it went completely away, the action for every single sign is the same. Call 911. Not in the morning, not after rest, now and immediately. There are 3 things you can do tonight that cost nothing and matter enormously. First, memorize be fast, balance eyes, face, arms, speech, time to call 911. Say it out loud twice right now. If you remember nothing else from this video, remember those 6 words and what each one stands for. Second, tell one person, a spouse, a sibling, a neighbor, an adult child. Tell them specifically about the TIA, the warning that passes and gets dismissed, because when symptoms resolve, the person experiencing them is the least equipped to call for help. The person next to them is often the only one who can. Third, if you have any known risk factors, atrial fibrillation, high blood pressure, diabetes, a prior TIA, or a family history of stroke, schedule a dedicated conversation with your doctor about your stroke risk, not as an add-on to a routine visit. As the main agenda item, The 80% risk reduction the research shows after urgent TIA treatment exists, but only for people who seek care in time. Take care of yourself. You came here to learn something that could save a life. Act on it. Before you close this, I want to hear from you. Have you or has someone close to you ever experienced any of the signs on this list, especially a symptom that resolved and was not acted on? Tell me in the comments below. Your experience genuinely helps other people reading through them recognize what they may have gone through, and it helps me understand what to go deeper on next. If this video gave you something, a test to remember, a conversation to have, a sign to recognize, please share it with one person in your family or circle. Not for this channel's sake, because there are people around you who do not know that a mini stroke that passes is not permission to relax. One share may be the thing that changes that for them. Next week, I am publishing a video on 5 foods that neurologists consistently link to higher stroke risk after 60, including one that nearly every senior has on their breakfast plate right now, thinking it is a heart-healthy choice. The research behind it is surprising. The alternative is simple. Watch for that one. I will see you there. Take good care of yourself.